Bismillahirrahmanirrahim. So our next topic after GBS, after neuropathies, is the epilepsy. So let's talk about epilepsy. Okay. So epilepsy is basically an recurrent tendency to have seizures, right? So recurrent tendency to have seizures is called as the epilepsy. So there should be at least two seizures in two different time and space, right? So basically, we can say that if we have more than two unprovoked seizures in a patient, so we're going to call it as epilepsy. So how we're going to define seizure? Seizure is basically an abnormal clinical event that results from the abnormal electrical discharge from the cerebral neurons. So it can be from motor cortex, it can be sensory, visual, and psychic, right? So abnormal electrical discharge means discharge can increase, discharge can be decreased. So if we see abnormal electrical discharge in a motor cortex, so that is called as convulsion. So basically, motor component of seizure is called as convulsions, right? And if electrical discharge decreases, so we can see that in absent seizure, right? So in absent seizure, there will be decreased electrical discharge. Let's talk about types of epilepsy. So we have two types. One is called as primary and secondary. Then there is another classification. We're going to classify that into. Previously, we used to call it as partial and generalized seizures, but we call it as focal and generalized seizures, right? So I'm going to discuss the classification on the next page. So let's talk about types of epilepsy. We will have the primary, that is idiopathic. So mostly 90% of these patients will have the first seizure in less than 20 years, right? And we're not going to find any underlying cause of that. The next type that is called as secondary epilepsy. So there will be some leading cause is hypoglycemia, right? So we have discussed the vitamin mnemonic in the delirium part, right? In the confusion part. So vitamin is basically vascular infection, inflammation, trauma, alcohol intoxication, hyperglycemia and metabolic cause like renal and liver failure. We're gonna call it as uremic encephalopathy or hepatic encephalopathy, and there will be electrolyte imbalance and neoplasm and toxins. So these are the causes of secondary seizures, right? So there are some drugs, right? So these drugs can induce seizure in an epileptic patient. So we need to avoid giving these drugs to the epileptic patients. So these are the quinolones, penicillin, metronidazole, isoniazid, nitrofurantoin, and cyclosporins, right? Okay, so let's talk about genetic part of the seizures. So we have two syndromes. That is, one is called as tuberous sclerosis. The second one is called as the Sturge-Weber syndrome. So these two neurocutaneous disorders, these are related to the epilepsy, right? So let's talk about these two neurocutaneous disorders. All right. So tuberous sclerosis is basically an autosomal dominant disorder, right? So we'll have two genes that is called as TSC1 gene and one is TSC2 gene. So one is present on 9 and 2 is present on 16 chromosome. So what happens because of these abnormal genes? So we'll have hematoma formation, right? Hematoma are basically jumbled up tissues, right? So these can be present in the skin, in the brain. These can present in the kidneys and lungs and heart. So let's talk about skin manifestations which are present in tuberous sclerosis. So one is called as the adenoma sebaceum, right? Adenoma sebaceum is basically a nodules, acneiform lesions or nodules like lesions. These are present over the nose and the cheeks in the butterfly distribution. So this is not butterfly rash. This is acneiform lesion in the butterfly distribution, right? And another manifestation that we can see in these patients is called as shagreen patch. So shagreen patch is basically a silvery gray, like shock, like lesion on the skin, right? And another one is called as ash leaf macules, right? So this is earliest manifestation. Ash leaf macule is basically a hypopigmented macule that is present over the trunks, right? And another one is called as the subungual fibroma. Like we see the skin growth on the nails, that is called a subungual fibroma, also known as conian tumor, right? So these are the skin manifestations we can see in patients with tuberous sclerosis, right? So talking about the neurological manifestations, so if these hematomas are present in the brain, so they can cause fits, right? So if it is present in the newborns in the less than 1 year, so this can cause infantile spasm. I'm going to discuss it in the next few slides. So we can give the vigabatrin in these patients for a treatment, right? And for if the child is having more than 1 year age, so this can cause focal seizures. We can give the carbamazepine in these patients. If we get the CT brain, so we're gonna see the periventricular lesions, right? So these are called as the subependymal astrocytomas, right? So these are diagnostic of the tuberous sclerosis. And our kidneys, and the next part is we can see these hematomas, jumbled up tissues in the kidneys. So basically these are the angiomyolipoma, right? So they can spontaneously bleed into the kidneys, into the adrenal gland, and we're going to call it as Wunderlich syndrome. Wunderlich syndrome, right? So there is another syndrome that is called as Waterhouse-Friderichsen syndrome, that what we see in the patients with meningococcal meningitis, and because of the DIC, so these patients can bleed into the adrenal gland, so that is called as Waterhouse-Friderichsen syndrome. So this is called as the Wunderlich syndrome. Right, so these jumbled up tissues can be present in lungs and hearts as well. So let's talk about the next syndrome that is called as Sturge-Weber syndrome. This is second neurocutaneous disorder. So we're gonna see the port wine stent. So this port wine stent will be present in trigeminal nerve distribution. These patients are gonna have the recurrent seizures, and this will be in unilateral, in the unilateral form. There will be mental retardation, and there will be glaucoma, and there will be buff ophthalmos in the patient. So this is basically the Sturge-Weber, right? So STURGE, right? So Sturge is basically mnemonic for the manifestations of the Sturge-Weber syndrome. So if you get the CT scan, non-contrast CT scan, we're gonna see the Crom track appearance in these patients, right? So that's all about the tuberous sclerosis and Sturge-Weber syndrome. So let's move on to the next page, and let's discuss another syndrome that is called as VHL, von Hippel-Lindau syndrome. Okay, so VHL. So let's talk about this thing. Okay, so VHL is basically an autosomal dominant disorder. It is defect of chromosome number 3, that is VHL gene defect. So we can see the three tumors: cerebellar tumor, renal cell carcinoma, and retinal tumors in these patients. So basically we have these three. This is just to memorize, I think. VHL gene that is present in chromosome number 3. So these are three words. So we have three types of carcinoma in these patients. So this is also related to epilepsy. So let's classify the seizures. All right, so previously we used to call it a partial and generalized seizure, right? Now we call it as focal and generalized and unknown type. Further, we're going to divide this focal seizure into motor and non-motor type, and also we're going to divide the generalized into motor and non-motor type, right? And so we have this focal subdivided into motor and non-motor type, and generalized is also divided into motor and non-motor type, and unknown cause, right, is also divided into motor and non-motor type. So this slide is taken from the Davidson 24th edition, right? So let's talk about focal seizures. All right, so focal seizure can be motor, can be of motor onset, can be of non-motor onset, and focal seizure can be with intact awareness and without, and focal seizure without, you know, with the altered level of consciousness. Focal seizure can be, like previously it was called as secondary generalized, now it is called as the focal seizure evolution into GTCS, right? That is called as generalized tonic-clonic seizures, and it will be preceded by aura, right? So focal type, focal seizures. So let's discuss these examples of focal seizures. So one is called as the Jacksonian seizure, right? So it will start from, you know it will start from proximal to distal end. It will start from the angle of mouth and it marches to the upper limb, or it can start from the upper limb and march to the face, right? So this is called seizure when, uh, the jerks, twitching like activity that starts from the angle of mouth and then spreads to the upper arm till hand, or it can start from the hand, it can ascend upward, and it can, because we have in the motor cortex, the face area and upper limb area is near to each other, right? So if such type of seizure is called as the Jacksonian seizure, that start from proximal end and move to the distal end, right? And vice versa. So there will be march of seizure on the neck to the shoulder, then arms, and then ends on the thumb, right? Or it can reverse, like, and starts from the thumb and end up onto the face. So this is called as Jacksonian seizure. The next thing is thoughts paralysis. So after this seizure activity, patient will be having the paralysis or paresis in the body. It can, it can remain for hours to days, right? But there is recovery after that, right? So this is called as towards paralysis, right? This is called as towards paralysis. And another thing is, if this jerky movement continues for hours to days, so we're gonna call it as EPC, that is epilepsia partialis continua, right? So all right, so these are the types of the motor seizures, right? Basically motor focal seizures, right? So let's talk about non-motor types of focal seizures. So we'll have sensory seizures, right? Sensory seizures will have the visual seizures. We can have the psychic seizures, right? So these are the non-motor. Patient might perceive the, there are some paresthesia on the body for some time, right? Patient might see, when there is some visual hallucination type of things repeatedly, right? Patient will be having abnormal behavior repeatedly. So basically non-motor focal seizure patient, in these patients may have paresthesia, vertigo, and smell of rubber, burning, mycopsia and macropsia, right? So these are the types of non-motor seizures, right? Non-motor focal seizures. So in impaired uh, awareness, so patient will be having one seizure that is called as automatism. So in automatism, there will be vacant stare, right, first, and then patient will start chewing. There will be lip smacking movement. There will be swallowing movement. There can be picking movements. There can be uncontrollable laughter or crying. So it actually starts with the motionless stare. Then after that, patient will be having post-ictal confusion, right? Patient will be having antegrade amnesia, and patient can also have transient deficit like aphasia for some time, right? So this is called as the automatism, right? So this is an example of impaired awareness and focal seizure with impaired awareness, right? So that's all about the examples of the focal seizure. So let's talk about generalized seizures. So in generalized, we can again divide into motor and non-motor types. So in motor types, we'll have tonic-clonic type, atonic type, and myoclonic type. In non-motor type, we'll have the typical absence seizure and atypical absence seizure, right? So let's move on to the next page and let's discuss the generalized types of seizures, right? So let's talk about this thing. Okay, so absence seizure, previously it was called as the petit mal, right? So actually what happens in the absence seizure, so this is, I'm talking about the typical absence seizure. So this happens mostly in kids with 4 to 10 years of age. So in this seizure, child is gonna stop the activity for a few seconds. It's gonna stare blankly and then rolls the eye upward and fail to respond, right? So there will be loss of consciousness for 1 to 2 seconds, but the posture will be maintained. Postural tone will be maintained in these patients. So there will be no fall in these patients. So there will be before attack there will be repeated blinking of the eye, right? And there will be no postal ictal deficit, like if the child is eating the food from the plate, so he gonna if there will be repeated blinking of the eye, then he is gonna stare blankly, right? And after the attack, so he is gonna start eating again. um, right, so that is about the absence seizure. This is called as a typical absence seizure. So if we do the um, EEG in these patients, right, so there we can see the 3 per second spike and slow wave pattern, right? So just like that, we'll have this, we can see the spike and slow wave pattern, right, in 1 second in these patients if we do the EEG. And treatment for the typical absence seizure is, if the child is less than 2 years, we can give the ethosuximide, and if child is having age of 4 to 10 years, so we need to start the sodium valproate, right? So in atonic seizure, there will be postural tone is maintained in these patients of absence seizure, but it is lost in the atonic seizure, right? So there will be loss of consciousness, there will be postural tone that will be lost, and the patient will be having head down. Patient will, if we see the face of these patients, so because of the loss of tone, so there will be their head will be turned down, right? Okay, so let's talk about, we're gonna compare it with that of atypical absence seizure, right? EEG will help us to differentiate the typical and atypical. So in EEG, if we do that, so during attack, so there will be less than 2.5 hertz spike and slow wave pattern, right? So in the typical type, there will be 3 per second spike and slow wave pattern, but in atypical type there will be less than 2.5 spike and slow wave pattern, right? So in typical type, the attack is for 1 to 2 seconds, right? But in atypical type, attack is for 10 to 15 seconds, right? And atypical is also associated with mental retardation, related with the some syndrome that is called as Lennox-Gastaut syndrome, right? So that's all about typical and atypical types of absence seizures, right? So let's talk about atonic seizures, right? So I have already talked about a little bit about this thing before with the absence seizures. So there will be decreased activity in atonic seizure for a few seconds, and there will be suddenly tone is lost for a few seconds, 1 to 2 seconds, and there will be patient might fall in these, might fall because of loss of tone, and there'll be, head will be, like hanging down, right? Okay, so this is related to decreased electrical activity, and we're not gonna find any post-ictal deficit. So these are the conditions: the febrile seizures, absence seizure, and tonic seizure. There will be no post-ictal deficit in these patients, right? So let's talk about the third type, that is called as the myoclonic seizures, right? So in these patients, there will be sudden violent jerking of the limbs, right? And patient is gonna complain that my limb become disobedient, also called my flying saucer epilepsy, right? So this is related to neurodegenerative disorder. This can be seen with the variant Creutzfeldt-Jakob disease. It can be associated with the metabolic encephalopathy, anoxic cerebral injury, high altitude cerebral edema, right? So we're gonna see the myoclonic seizure in these patients, right? So another thing is called as the epileptic spasm, right? Also known as slam seizures. So in these patients there will be trunk muscles will be involved, right? And arm movements will be disturbed in these patients, right? So when the attack happens, so patient is going to bend forward, right? So this mostly occurs in infants, right? So like doing slam, right? So if we do the EEG in this patient, we're going to see the grossly chaotic pattern that is called as hips arrhythmia, right? So this is basically as hips arrhythmia, right? Okay, so let's talk about the GTCS, that is called as the generalized tonic-clonic epilepsy, right? Tonic-clonic seizures. Previously it was called as the grand mal epilepsy. So this is GTCS. So let's talk about this thing. So there will be premonitory symptoms in these patients. There will be prodrome hours today. There will be hours to days before attack. There will be unease and irritability in these patients, and there will be aura, right? Like seconds to minutes before the attacks, right? And aura will be like patient will be having hallucinations, olfactory. It can be olfactory, visual, and can be sensory hallucinations. So patient might feel pain, and if we check the reflexes, so there'll be um, you know brisk tender reflexes will be exaggerated, right? So this represents that imminent fit will occur, right? So after aura, patient will be having a tonic phase, right? When the JTCS, when the generalized tonic-clonic epilepsy or fit starts in these patients. So first one is called tonic phase. So there will be rapid electrical discharge that remains for 15 to 30 seconds. So arms will be like flexed and adducted position. Legs will be in extended position, right? And there'll be a cry, and this will be due to diaphragmatic contraction, right? So the patient will be having cry. So this is called as the ictal cry, right? So this is called as ictal cry. And because of the closure of the vocal cords, so patient might have the cyanosis, right? And after that clonus starts, right? After tonus, the clonic phase is gonna start. So it will remain, if it remains for more than 5 minutes, so we're gonna call it as status epilepticus, right? Okay, so in chronic phase, there will be less electrical discharge for 1 to 5 minutes, and because of that, so there will be violent jerking of the limbs, right? Previously, when the tone gets increased, so there will be uprolling of eyeballs, right? And there will be clenching of the teeth, right? And due to contraction of diaphragm, there will be ictal cry. So in the chronic phase, so there will be tongue bite in these patients, right? There will be violent jerking of the limbs, head and neck, right, and the chest, and there can be urinary incontinence, and if we can see the swelling of clothes, right? So patient might pass the feces and the urine, right? So we after the attack, because some if patient eaten something before attack, so he's gonna aspirate those things, so we can see the noisy breathing in these patients and cyanosis, right? So in post after that, after tonic phase and clonic phase, there will be post-ictal phase, right? So there will be deep unconsciousness, right? And after arousal, so if after arousal there will be headache and violent behavior, right? There will be noise breathing, and stool and urine can be passed. Right, so that's all about the types of epilepsy. So I'm going to discuss the management part in the next video. So that's all for today.